Our next speaker is going to be Dr. Sahil Goel, who is a cataract, cornea, and refractive surgeon from Ludhiana, who is going to elaborate on the most quintessential aspect of refractive surgery, that is topography, a detailed understanding.
Hello, good evening, everyone.
I think, Sahil, I think this is very important because they get topography maps to see in their Grand Viva and also as a part of their doc with the instruments, etc. So this is very important.
Absolutely, ma'am. Will try my best to do justice to the topic given to me. Time 10 minutes seems a little less, but I'll try to cover the basics. I try to have some discussion with my own residents in the morning that what are the problems they face while interpreting topography maps, and hopefully I'll be able to take everyone through. Thanks. Very good evening to all the panelists, and thanks to Dr. Chitra for giving me this opportunity. I would like to start with this evolution. This is one of my favorites, that how we have evolved from simple keratometry.
You have to make the slides bigger. It's still on. It's not on the presentation mode.
Slideshow.
Okay, it is slideshow mode. Okay, sorry. Yeah. Yeah. Hopefully it is better. Yes. Okay. Thank you. So we evolved from keratometry to video keratography to optical sectioning, and currently what we are using is corneal tomography, which is a three-dimensional modeling of the cornea, which involves anterior and posterior corneal surface. It probably essentially began in 2010 during my first year residency when we first got access to Pentacam. And luckily my thesis was on Pentacam, from where I got really in love with this topic of corneal tomography. So what we essentially do now is we make multiple optical sections of the cornea. With op scans, it used to be parallel sections with no overlap. With our current tomographers, they all have a central overlap. And essentially what we are using is Pentacam, Galilee, and Sirius. Pentacam, I think, is the most commonly used instrument, and I think that is what we are going to be talking about the most. And OpScan, because it involves optical sections without having any common overlap, is something which is a little obsolete. Whichever instrument it is, I think one of the most important things for the residents is not to really get distressed if they see a different tomography machine or a different sort of color coding. What essentially you have to understand is the interpretation of a tomography map or a basic quad map stays the same, irrespective of what instrument or what machine you are using. Before I go into detail, just in brief, a basic principle. Most of these machines use a Scheimpflug camera, which basically increases the depth of focus of the camera, whereby various objects at varying instruments at varying distance from the lens plane are brought into focus at the image plane. I'm not going to compare various instruments. I'll start with Pentacam, which essentially has a central camera to adjust for the eye movements, and a peripheral Scheimpflug camera, which rotates 360 degrees, takes multiple cross-sectional images of the cornea, and using edge detection software, we can further go ahead and calculate the elevation of each point. Before I go on to interpretation of a topography or a quad map, for the residents, please understand that this thing, which is one of the oldest by Rabinowitz and McDonald, to date still stays the mainstay for diagnosis of keratoconus. No matter where you are, no matter which hi-fi machine you are using, please do not forget about the basics. And the basic was Rabinowitz-McDonald criteria, whereby a K value of 47.2 and inferior superior asymmetry of 1.4, these were the two cutoffs given. After that came KISA index, in which, in additional to this, astigmatism and skewing of radial axis was also considered. So I believe that if you are clear about these four basic criteria, you'll be able to interpret the corneal curvature maps, anterior topography easily. So this is how a basic quad map looks like, and these are the numbers given. Depending on what color coding you are using, again, which is customizable, the color maps might look different, and machine to machine, the color coding might vary. But what you essentially need to look at is the basic numbers and the pattern. As I said in the previous slide, you need to look at the central keratometry and inferior superior asymmetry. You have to understand ectasia basically manifests in corneal curvature as a basic asymmetry. It can be inferior superior asymmetry, it can be right eye left eye asymmetry, or any asymmetry which can be initial manifestation of ectasia. Yes, posterior maps are also important, But let's first start with the front maps. So this is the axial map, and as you can see, 41.7, 42.3, the inferior superior asymmetry here is less than 1.4. And here, as you can see, 45.6, 53.2, there is high inferior superior asymmetry. This is one of the foremost criteria. Astigmatism with the rule most often will be normal. If it is with the rule, we mean that 90 degrees steep axis. If it is oblique or against the rule, that is sort of a red flag sign. After you have done read the corneal curvature, the Kmax, that is a maximum keratometry, the inferior superior asymmetry, and the astigmatism, next in a quad map, you can jump to the elevation maps, whereby it is essentially an imaginary sphere, or what we call a best fit sphere, and every point is calculated by how much microns it is above or below that imaginary best fit sphere. So the cutoffs used, say, generally in Pentacam, the cutoffs would vary from machine to machine. Generally, the cutoffs used in Pentacam for the anterior best fit sphere would be 15 microns, for the posterior would be 20 microns. Pentacam and Galilee probably differ in this way that Galilee generally advocates in its indices, saying that the toric aspheric is a better reference surface, that it increases the sensitivity to pick up keratoconus, while Pentacam essentially relies on best fit sphere, or as I will be becoming an enhanced ectasia reference surface. So this is the basic sagittal map. These are the front and posterior elevation maps. This are the indices used by various tomographers to help you interpret the tomography. Please understand that these indices, like for Pentacam, we commonly use Bellin-Ambrosio display, are not the basic of corneal tomography interpretation. These are just external aids for the clinician to help understand and interpret the tomography easily or in a fast way. But this is not the basic. Please do not replace this with a quad map. If someone sends me Bellin-Ambrosio and asking me that whether this is keratoconus or not, my first question would be, please send a quad map. And this quad map is something what continues to be the basic for interpreting corneal tomography. So if in 1 minute I can brief up the basics of Bellin-Ambrosio, what they basically do in Pentacam is they exclude the central 3.5 mm zone, derive another best fit surface, and a difference between the elevation points of two is what is reflected in this difference. So depending on the cutoffs, they have divided yellow as form first and red as keratoconus. This is deviation of front surface. This is deviation of back surface. Pentagam gives maximum weightage not on the thinnest point but on pachymetry progression index, which is nothing but concentric circles drawn on the thinnest point of the cornea, and how the corneal thickness increases as you go from thinnest towards the outermost cornea. So this is pachymetry progression index, and the Bellin-Ambrosio what we are using is the BAD3 that gives maximum weightage on ART3, that is ambrosial relational thickness, in which that is the thinnest pachymetry divided by pachymetry progression index. So every machine would give weightage to different things, and Pentagam gives maximum weightage in its index to enhance ectasia display or Bellin-Ambrosio display, whereby this pachymetry progression index and the this bad display is given maximum weightage. But as I'll be showing, that bad is not the final decision maker. This is one of the external validation first studies about Pentacam, which showed the sensitivity and specificities of various Bellin-Ambrosio deviation maps. The overall D is what we should generally look at if you are in a hurry. Individual DF, DB, all 5 deviation maps, sometimes you might get up alert that this is individual D is yellow or individual D is red. Please do not give any value to it. These from sensitivity and specificity data I have extrapolated, presuming a prevalence of 5 to 10%, that the positive predictive value of individual D as red will only be say 30 to 40%. Overall D, which we give maximum weightage to, even that would have around 60 to 70. That is best case scenario, a 2/3 positive predictive value. 1 in 3 overall D, yellow or red, might not be keratoconus, but at the same time, they have a very high negative predictive value. So overall D of white, most likely 99.9% is not keratoconus. But overall D of yellow or sometimes even red, you again have to go back at the quad map or clinical, say look for scissoring reflex, look for retinoscopy, look for slit lamp signs to diagnose whether this is a patient with keratoconus or not. In absence of time, I'm not going to go much into details of Galilee, but quickly, I think Galilee has 2 or 3 advantages. It has dual stream flux camera, it has auto alignment and motion compensation, and it gives more weightage to the central cornea in extrapolating a quad map, driving a refractive quad map. This is the basic of why in the central cornea a placido disc based imaging system is more reliable, and in the periphery a Scheimpflug camera is more reliable. I'm not going to talk much about Galilee, but these are some of the indices KPI and K probability, which, as I said, use slightly different methods to diagnose keratoconus. So every tomographer might have its own indices. Please do not get confused. Stay with the basic of interpreting a quad map, and the basic of interpreting a quad map stays in, first of all, sagittal curvature, whereby you look at inferior superior asymmetry, astigmatism, skewing of radial axis, especially if the astigmatism is against the rule or oblique. So I think this is one table which I think would be relevant for the residents especially. These are the suggested cutoff maps on elevation maps for pentacam and galilee. For pentacam, on anterior best fit sphere 15 microns, posterior would be 20. For galilee, if you are not using a toric aspheric, that is you are using a simple sphere as a reference surface, 12 and 16 microns will be the suggested cutoff for you to be able to diagnose keratoconus. All right, I think with that I would like to end the talk. I think we are up with the time. If we have any questions from residents, we can take it up.
Naga, you keep looking at the moderator's link. And one very simple question. When do we ask the topo to be repeated in case it's has suspicious findings?
All right, sorry, I didn't touch upon the quality markers. So in a basic quad map, say in pentacam, or every instrument would give you a QS, a quality marker. So again, pentacam makes our job easy by making it color coded. So just like say for perimetry, Humphrey perimetry, you have positive and negative, that how reliable it is. Similarly for pentacam, you have this quality marker, and this should be okay or white. Yellow or red, ideally it should be repeated. Also, sometimes you might have something what we call contact lens warpage, where there would be the two axes would not be bang opposite. There will be slight variation in the steepest or the flattest points, in which case you might want that there should be, you ask the patient to apply lubricants and repeat the topography.
Yeah, like inferior superior asymmetry in a sagittal curvature map, which doesn't correlate with the other findings, or a decentered apex. These are other things besides what Sahil has very well. Of course, some data points are missing, is something very, very basic. You would immediately do it again, I guess.
So this is not visible in this map, but yes, sometimes pentacam extrapolates the data beyond what it is able to capture. And those areas are highlighted in black dotted areas. So whenever you see, especially in the periphery, there are black dots, sometimes covered by the eyelid or some other obstruction, and you see black dotted structures, that means that data has been extrapolated to beyond what it has actually been able to capture. That would be another indication when you would want to repeat the topography. But essentially, Q value, quality value is essentially which sums up most of these quality markers. And if you want to be in a quick fix, then look at the quality value. If it is okay or white, then more often than not you are good to go. If it shows yellow or red, then you probably need to repeat the topography. Severe dry eye patients, very irregular corneas, of course, it's very difficult to get a very good repeatable topography.
One question is how long should the patient stop wearing contact lenses before doing topography? I mean, that is something that the postgraduate should know for rigid lenses and for soft lenses.
Right. So for soft lenses, it would be at least 1 week. For rigid lenses, it will be at least 2 weeks. Lot of times, especially keratoconus, when you ask them to come for follow-up to establish whether there is progression in topography, patient, sometimes you forget to ask, you'll get a topography and then realize that there has been sudden progression. And then you go back and ask the patient that when was the last time he or she used a contact lens, and he would say they used the RGP only yesterday. So sometimes that can lead to artificial steepening or flattening in various areas. So that's a very important question, especially for keratoconus patients, when you are trying to assess whether there has been progression in topography, that they should have discontinued the rigid lenses for at least 2 weeks. Soft are generally patients who are come for refractive screening. So before you take up any patient for LASIK and get a tomography, please make sure that they have discontinued contact lenses, soft lenses at least for a week.
Presentation. Excellent presentation, Sahil. I think you covered everything in 10 minutes. Just a couple of queries for the sake of postgraduates. I mean, how do you identify contact lens warpage? And secondly, about the color coding, why can't you directly compare two maps taken out of different instruments, and what is the kind of coding that we use?
Okay, so depending on how advanced, say sometimes most of the normal people will have corneal curvature values between say 40 and 48. So you do not really need to have small color coded changes for normal people, but in advanced keratoconus, where corneal curvature would go up to say 70, 65, 75, you will probably need to change the grading. The color coding scale used by various tomography machines are different. They are German and American scales, which at first appearance might look very different. So someone very used to seeing a op scan, when they see a pentacam or say a galilee, the color coding will be different, but you have to interpret based on what the actual color coded map says from the side. So as you can see here, these are the numbers. So blue is 40, green is 42, 44 is yellow. So for normal patients, as you can see here, from 30 to 40, there is only a 2 diopter gap. And
Yeah.
after 50, you suddenly have a 10 diopter gap. So 50, 60,
Sahil, I
70,
think
80.
we can't see your screen, Sahil, I think.
Yeah, you
Okay.
can just explain it.
Okay.
And also what they just need to know is what a keratoconus map looks like, what a keratoglobus map looks like, what a pellucid marginal degeneration looks like from their exam point of view. But just share your screen, I think.
Yeah, so I'm trying to do that. Yes, so I think screen is now being shared. So as you can see, most of the curvature maps would have this kind of gradation, 32, 34, 36, 38, 40, 42. So till 60, there is a 2 diopter difference. And after 60, suddenly it is a 10 diopter difference. For keratoconus patients, sometimes we would change this gradation. And this color coding, like for 40, it is blue. So from German and American scales, this color coding would vary. But the interpretation is not dependent on the colors. The interpretation is dependent on actual numbers. And what I think Dr. Ramamurthy first tried to ask was, how do you make out a contact lens warpage? So as I said, like this is a normal cornea where the two steep and the flat meridian are bang opposite each other. In contact lens, especially soft lens induced warpage, sometimes you would have more or less similar numbers, but the two axes will not be bang opposite. So it will be sort of a Y-shaped thing. Uh, Sometimes one might get confused with PMCD or sort of a crab claw appearance. But if you actually look at the numbers, numbers are not actually very different. So severe eye rubbing or soft lens usage can lead to axes which are not bang opposite to each other. And these patients probably need to discontinue lenses, give lubricants, and then maybe repeat the topography after a week.
Good, Kyle. That was a nice answer.
Could you also touch upon the difference, and when would you use a tangential map instead of an axial map, and the difference between that, just very briefly?
Okay, so sagittal and tangential maps depend on the reference surface, on the axis in the sagittal curvature. Tangential is basically the exacerbation of a tangential curvature. In that, you are not taking the corneal curvature and presuming that there's average from the central reference axis. Tangential curvature is the instantaneous curvature at that very point. Accentuated, it's sort of the small changes are really exacerbated in a tangential curvature. So sometimes that can lead to artificial noise, which probably is not really good. And sometimes that initially can lead to false interpretation of keratoconus. So as probably if my screen sharing, yeah, is still on. As you can see, this one is essentially high, with the rule astigmatism, 1.9 diopters, bang opposite, no swing. And if you look here at the tangential curvature, there seems to be a localized island around here, yellow color, which seems to be slightly elevated. This is 44, 42.5. This yellow island seems to be slightly elevated. So tangential curvature would tell you the exact location of the cone and how the cone is flattening. But at the same time, to detect keratoconus, sometimes tangential can lead to artificial noise because it is not averaging from the central reference axis. It is calculating the exact curvature at that very point.
Thank you so much.